So now I'd like to introduce you to our speaker, Susan Smith. Dr. Susan Smith is a family practitioner and professor of primary care medicine at the Royal College of Surgeons, a medical school in Dublin, Ireland. She is PI on several studies developing and evaluating cost-effectiveness of interventions for patients with multimorbidity and polypharmacy. She leads the HRB Collaborative Doctorate Program in Multimorbidity and Associate Director of the HRB Primary Care Clinical Trials Network in Ireland. Thank you so much for joining us, and I'll let you take it away.
Thank you very much. Can you hear me okay? Good, all right. So I'm going to talk about developing a complex intervention for patients with significant polypharmacy and multimorbidity. And while I take full responsibility for the contents of the webinar myself, it is very much based on the work of my colleagues, Dr. Caroline McCarthy, Dr. Frank Moriarty, and Dr. Barbara Klein. And I just wanted to acknowledge that at the start. So I am a family practitioner, or we would say a general practitioner, or GP, working in Dublin, in Ireland, and I also work in one of the medical schools in Dublin in the Department of General Practice, where we have the HRB Centre for Primary Care Research. Sorry, now I've got to work out how this will. Yeah, so I have no conflicts of interest other than, I suppose, being very interested in this from an academic perspective, but there's no financial issues that I would have any conflict with. So I'm going to start off by talking for a bit about the context in which we've developed this intervention, looking at evidence around polypharmacy and potentially inappropriate prescribing, and also multimorbidity. And I know the audience for this webinar is probably very familiar with this literature, but I am going to talk particularly about research that we've done in our own centre over the last 10 to 15 years, because it provides background as to how we have reached the point that we did with SPIRE. And I'll go on then to describe the development of the SPIRE intervention and how we have incorporated deprescribing within this complex intervention. So it all begins with patients and trying to support frontline clinicians managing patients. And when we think about a patient for deprescribing, they usually have polypharmacy, and we know that medication counts are a very strong proxy for condition counts. So usually people with polypharmacy also have multimorbidity. Polypharmacy is associated with potentially inappropriate prescribing, or PIP. And then more recently, people are recognizing prescribing cascades. And one of my colleagues, Dr. Emma Wallace, is doing work on that. And that's essentially prescriptions that arise as a result of either an inevitable consequence of a needed treatment or an unrecognized side effect of existing treatment. And both PIP and polypharmacy and prescribing cascades are associated with adverse events. And we also know that multimorbidity is associated with increased treatment burden for patients. So deprescribing is happening in the context of these different areas. And in some ways, they have all slightly developed different research strands. And I suppose one of the key messages this evening for me is around how do we try and pull them all together and make sense of all of this complexity. So we're all aware of the increased trends in polypharmacy, and this is work that was done by Dr. Frank Moriarty, who looked at prescribing across the age range, and this is a national database of prescribing in Ireland. That covers 40% of the population, those who have the lowest income. And you can see over the years between 1997 and 2012, the green and dark green colors are those who are on 14 or 15 or more prescribed medications. So in 1997, most people over 65, about 10% of them might have been on 7 or 8 medicines, or maybe a little bit more. But by the time we get to 2012, about 5% of this population were on 15 or more medicines. So there's been an explosion in polypharmacy, which we're all aware of, almost certainly driven by single condition clinical guidelines, increasing medicalization, but also probably relating to prescribing cascades, with one medication being used to manage the effects of another. So polypharmacy has a significant impact both on patients and on healthcare systems. It poses really significant challenges for prescribing in primary care. And all of these findings are based on research that has been conducted in our own centre, but we are aware that there's a definite link between potentially inappropriate prescribing and high-risk medication prescribing and adverse drug reactions. And the prevalence in Ireland, which is similar to the UK, of PIP in over 70s is about a third of those over 70 have at least one potentially inappropriate medicine prescribed. It's also associated with healthcare utilization with higher rates of general practice and emergency department visits. It's associated with increased expenditure and also for patients with poorer health-related quality of life. Dr. Barbara Klein conducted the OptiScript trial, which I'll come back to later because it was the forerunner for SPIRE. But one of the secondary analyses she did was a very interesting study looking at the beliefs about prescribed medication in older patients with polypharmacy. And this was a mixed method study amongst the OptiScript participants. And it showed these really interesting coexisting positive and negative attitudes towards medicines. So 96% of patients believe strongly in the necessity of their medications. But meanwhile, a third of them also reported strong concerns about the potential for adverse consequences, which seems a little bit contradictory. But the main theme that emerged from the qualitative part of that research was a strong sense of trust that these patients have in their family doctors. And this quote, I won't read out the whole quote, but essentially what it's illustrating is this trust. The patient saying, well, that's what we go to the doctor for, isn't it? To be told what's good for your body. And we need to be aware of this context in which deprescribing has to take place if it's going to happen, if it's going to be successful and effective. Looking at the evidence around interventions for polypharmacy, our colleagues in Queen's University in Belfast are the authors of the Cochrane Review of Interventions to Improve the Appropriate Use of Polypharmacy in Older People. And the 2018 update identified 32 studies across all healthcare settings. And while it did show that there were significant improvements in medication appropriateness measured by measures such as the MAI, and there was a reduction in PIP or potentially inappropriate prescribing, it was uncertain what the clinical impact or significance of these improvements were. And there were other methodological issues that were raised in the review. Dr. Barbara Klein also conducted a systematic review that had a slightly tighter focus. It just looked at interventions that were specifically targeting PIP or potentially inappropriate prescribing in primary care. And that review, published in 2016, found 12 randomized controlled trials and similar findings, some weak evidence indicating reductions in PIP and a suggestion that multifaceted approaches, pharmacists delivered interventions and computerized decision support systems may be effective, but uncertain cost effectiveness for interventions, and again, an lack of certainty around the clinical impact of some of the findings. So if we switch then to looking at the context of multimorbidity, many of you will be familiar with this graph. It's based on the Lancet paper in 2012 from Scotland. And what it's showing you is the prevalence of multimorbidity across the age range. So you can see the proportion of patients with 2 or more conditions rising as people get older. But what's particularly important about this graph is that it also shows us the difference between those with different socioeconomic status. So the red line are the group who are from the most deprived populations in Scotland, and the black line are the most affluent. And what you're seeing is that those in the most deprived areas are developing multimorbidity about 11 years ahead of the most affluent. And this is something we need to remember in the context of deprescribing, because we sometimes think of deprescribing in the context of very elderly patients, maybe towards the end of life. But of course, your proximity to death varies a lot depending on your socioeconomic status. Then this is more data from Scotland showing the impact of multimorbidity on patients and on clinicians and healthcare systems. So this is showing you differences again between the most affluent and the most deprived patients. The blue line is standardized mortality below the age of 75, and the red is physical mental comorbidity. And what you can see is, as you would expect, far higher prevalence in the most deprived groups. But what's interesting is that the green line shows you the consultations for every 1,000 patients registered with a GP, and the black line is the funding per patient registered. Now, Scotland is a country with a universal, very well functioning primary care system that's accessible to everybody, and they also have deprivation weighted payments in general practice. So if this kind of disparity exists even in a system like that, it's likely to be much worse in other systems. And what you're seeing is that the GPs in the most deprived areas have about 120 consultations for every 1,000 patients registered, whereas in the more affluent, it's about 100. So they're really, and that difference is enough to make them really struggle to keep up with their patient demand. The other thing I just want to emphasize in relation to multimorbidity is the concept of treatment burden, which again is familiar to everybody now. This is the image from the paper that was originally published in the BMJ 11 years ago now, led by Carl May with colleagues like Francis Mayer from Glasgow and Victor Montori from the US. And again, this crazy idea that in some ways the treatments that we are giving people are potentially more burdensome or worse for them than the actual conditions that they're living with. So looking at evidence around interventions for multimorbidity, we published the Cochrane review of this in 2016. And we've been recently updating this review. Now, we're not going to do it within Cochrane anymore because we want to focus on general multimorbidity. And we're now going to exclude comorbidity, which was an issue that the Cochrane editors weren't as happy about. So we now we're just completing this now. We've 20 trials designed to address multimorbidity identified. And I'm just going to talk briefly about the 4 of these 20 that have a medicines management focus, particularly in the context of a Deprescribing webinar. So all of these 4 medicines management in multimorbidity trials all had complex interventions. The first was from the UK in good long time ago now, targeting patients with an average of 4 conditions. And this was, pharmacists were placed in general practice to try and address any prescribing issues. And they reported a significant improvement in resolved pharmaceutical care issues. Unfortunately, that was an outcome that was kind of for that study, so it's very hard to know how generalizable it is. And then there's a sequence of randomized trials, all really well conducted and all interestingly from Germany. The first in 2016 was a stepped wedge cluster trial targeting GPs, but also patients with very significant complex multimorbidity and polypharmacy, with an average of 12 conditions and 9 regular medicines. And that did show a significant improvement in the medication appropriateness index. Then the next study targeted probably not as unwell a group of patients and didn't find significant improvements in their outcome, which was a summary score of 10 prescribing indicators. And then finally, Christiane Muth's trial published in 2018 called Primum, which again was a very well conducted cluster trial in general practice, but found no significant improvement in the medication appropriateness index. And I think largely because they targeted patients using the kind of the older definition of polypharmacy, which was 5 or more medicines, which increasingly is the norm. And at baseline, these patients didn't particularly have a lot of issues with their medicines, making it hard to show any benefit. So in terms of evidence-based clinical management, the guidelines that have been emerging over the last 10 years are also guiding intervention development. So a very significant guidance published in 2016, led by Bruce Guthrie in Scotland, the NICE UK multimorbidity clinical guidance. And interestingly, it recommended using medicines as a way of targeting patients and suggested targeting patients on 10 or more medicines and 1 risk factor, or 15 or more medicines for a multimorbidity approach to care. So you're to step back and you're to try and arrange their care differently on the basis of their multimorbidity. And then Christiane Muth led an overview of clinical guidelines for multimorbidity and polypharmacy that was published in 2018 that I was involved with. And most of these guidelines have overlapping recommendations around targeting at-risk, high-risk individuals, identifying patient priorities, effective communication, written care plans, and particularly conducting medication reviews and often recommending deprescribing. And what this overview recommended was that future guidelines should consider an integrated approach to management of multimorbidity and polypharmacy, which to date hasn't necessarily been in existence. So getting back to our complex patient, so this is the context in which we were trying to develop the SPIRE intervention. And I'm going to go on to talking about that now. So I mentioned the OptiScript trial earlier, and some of you may be familiar with it. And this was led by Dr. Barbara Klein. So it was a cluster randomized controlled trial with a process evaluation and economic evaluation published in 2015. It involved 21 practices and 196 patients, and it targeted patients over the age of 70 who were identified as having at least one PIP, potentially inappropriate prescription. So to be eligible, patients had to have a PIP. And the prescriptions were screened by a pharmacist to determine whether they had a PIP. And the intervention then was a medicines review using a web-based pharmaceutical treatment algorithm system. So the GPs were told what the PIP was, and they were given suggestions for addressing it. And OptiScript was effective in reducing potentially inappropriate prescribing, though this was mainly driven by an effect in modifying the prescribing of proton pump inhibitors. So many were being prescribed at high dose rather than at maintenance dose. And I'll come back to whether this is a clinically significant finding or not. The GPs involved in the study weren't as convinced that it mattered too much, but it does have an impact on costs. The overall, there was uncertain cost effectiveness of the intervention. So we've very recently published, led by Caroline McCarthy, the kind of the story of the evolution of SPIRE. We were, after OptiScript was published, we got funding for the Health Research Board, the Primary Care Clinical Trials Network that's led by Andrew Murphy in Galway. And OptiScript 2, it was called then, was proposed as one of the definitive national randomized controlled trials that would be funded through this new primary care trials network. And we decided that we would approach adapting OptiScript 1 into OptiScript 2 using a 5-step process. So we identified the core components of the original intervention. We were conducting, updating literature reviews to see what was happening, what was emerging in the evidence, and we modified the intervention based on that, conducted a small pilot study, and then final refinements to the intervention. So what was the emerging evidence? So this, you're talking around kind of 2015, 2016, 2017. Luckily we had Barbara had conducted a very comprehensive mixed methods process evaluation with OptiScript. So we had this message from the GPs involved that they weren't so sure about modifying some PIPs, particularly around proton pump inhibitors. And we were kind of conscious that high-risk prescribing would be of more clinical importance and impact, both for the GPs and the patients. But the idea of scaling up the approach in OptiScript at a national level, where you would have to identify everyone having a PIP, without being able to automate that in the electronic health record, it just wasn't that feasible to scale that up. So that was a challenge for us. And then just as we were thinking this through, Bruce Guthrie's team, was led by Tobias Deutsche, published a really impressive trial in the New England Journal of Medicine, which again you may be familiar with, called the DQIP trial. And they had 36,000 patients. It was a cluster trial targeting general practices. And the practices received electronic alerts around high-risk prescriptions. And it was able to pick up monitoring, blood monitoring of patients, and was also able to link to hospital data to look at emergency admissions. So we just simply were not going to be able to compete with DQIP. in terms of numbers, and they'd already shown that this was an effective approach. But the one thing they didn't have was patient-reported outcome measures, because they didn't get individual patient consent. It was the intervention was at a cluster level. So we were also aware of the Cochrane Review of Multimorbidity, which we had just updated, which focused very much on trying to target a specific issue for patients. And in this case, we were looking at the burden of multiple medicines. Meanwhile, there were NICE guidance and other guidances like SIGN and other ones across the world being published on multimorbidity, polypharmacy, and medicines optimization. And as I've mentioned, we were very conscious of this evolving idea of treatment burden, which originally began for conditions like heart failure, and diabetes, but was really becoming increasingly an issue for multimorbidity, where treatment burden can often be a very significant issue. And then also the evolving concept of deprescribing and trying to reverse this process of medicalization. So this was the context in which we adapted OptiScript into Spire. So the modifications we made, instead of going for over 70s with one PIP, we decided that we would go for over 65s who had significant polypharmacy. So you'll remember that the graphs I showed you earlier that Frank Moriarty had developed, and we had a lot of debate about whether we should go for groups who were on 10 or more medicines or 15 or more medicines. But we knew from Frank's work that about 5% of over 65s were on 15 or more medicines. So we thought that this would be an appropriate high-risk group to target, but they did have to be ambulatory. They had to be able to go to the GP to get a medication review and to participate in a kind of a shared decision-making type of intervention. And they also had to have cognitive capacity to sign a consent and to participate in the process. So we thought that they would be relatively well despite their highly significant polypharmacy. The intervention was adapted. It was still involved web-based GP supports, but we wanted to incorporate multimorbidity guidelines and address patient priorities to focus more on high-risk medications, not just general PIP. And this would involve a brown bag medicines review as well, which would incorporate the patient prioritization, and we were encouraging a deprescribing focus. And we also adapted the outcomes. Because of this deprescribing focus, we also included the number of medicines as well as the proportion of patients with a PIP as primary outcomes. And we added new patient-reported outcome measures to examine treatment burden and also patient attitudes towards deprescribing, which I know that some of you have also used. So this is the published protocol and the pilot that we conducted for Spire. And Spire, it aims to assess the effectiveness of a complex intervention designed to support GPs to reduce potentially inappropriate prescribing and consider deprescribing in older people with multimorbidity and significant polypharmacy. So in some ways, it's a bit like we've tried to get everything in, but that's what we have done. We're trying to pull all of these strands together, and time will tell whether we've taken on too much. But it's certainly been a challenging, but it is a very interesting trial to be involved in. So this is the PICO for Spire, just so that you can see for definite. I've described the participants. The intervention involves, so for OptiScript, there was academic detailing out in practices conducted by a pharmacist, but because Spire involves 50 practices and it has a national reach, that wasn't going to be feasible. So Caroline designed training videos that demonstrated the Spire medication review and also described the key concepts of polypharmacy, PIP, multimorbidity, and treatment burden, and then emphasized deprescribing. And then the GPs, once the patients had been recruited and the practices were allocated to intervention, the GP would then open up the Spire medication review template. And the first part of it involved guiding the GP through a screening of the patient's prescription for PIP and high-risk prescribing. And they were kind of, the website brought them through that, and they were the ones who identified whether there was any high-risk prescribing. But it also meant they had access to all of the patient's record. So it allowed us to incorporate higher risk prescribing issues like failure to monitor, say, combination diuretics and ACE inhibitors. And that meant we could expand the range of kind of medicines that were being reviewed. They then were invited to bring the patient in for the review and assess the patient's treatment priorities. And they were to review each medicine with the patient, doing this brown bag type of medicines review, and consider deprescribing where possible, and that all these changes would be agreed with the patient. The comparison was usual care. And as I've mentioned, the primary outcomes were proportions of patients with any PIP and the number of repeat medicines. And then secondary outcomes are listed there, but I've mentioned many of them already, and we'll get back to them now in a moment. So I'm going to now just present some of the baseline characteristics of SPIRE. I'd ask you please not to share any of this on social media. It's based on initial analyses, so things may change, and none of it is yet published. I think it's particularly interesting to consider this group of patients. We don't know very much about them other than from large administrative databases, but in this case, we also have all these patient-reported outcome measures as well. So who were these patients? The 404 included patients from the 50 practices. So they're a mean age of 76, 57% female, and they're high healthcare utilizers, a mean of 4.7 GP visits per person in the preceding 6 months. So they're visiting their primary care provider about 9 or 10 times a year. So their GPs probably know them quite well. The primary outcomes are available at the moment for 351 patients. Again, this is another issue that we had a lot of discussion about. One of the problems about doing a randomized controlled trial where you identify potentially inappropriate prescribing in all of the patients at baseline is what you do with it in the control practices from an ethical and a clinical perspective. And in OptiScript, what we had done was we had given the list of all of their patients back to the GPs in the control arm. And of course, some of them acted on that. Now, they didn't have the web-based support algorithms, but they did know what the PIPs were. And that would have reduced the intervention effect in OptiScript. Now, what we were doing in SPIRE was we were incorporating chart-based information as well as prescription-based information. And we just didn't have the resources to go out across these 50 practices all over Ireland and do chart-based reviews at baseline. So what we decided to do was that we would do the chart-based reviews for both time points at follow-up, which means that we're only establishing the primary outcomes at baseline now because we needed to get the chart-based data to be able to look at the potentially inappropriate prescribing. So for the 350 patients for whom we have primary outcomes at baseline, even though the entry criteria was 15 or more medicines, the mean at baseline was 17, and the mean number of PIP per person was 2.46, which is quite high for a population. In OptiScript, the mean number, even though they all had a PIP by definition, the mean number was about 1.3, 1.4. So there's a lot of potentially inappropriate prescribing going on in this group. And now looking at the patient-reported outcome measures, which are interesting, and they're not entirely as you might expect. So this has related quality of life measured using the EQ5D, and about a third of them report severe or extreme impairment in mobility, activities of daily living, and pain. And I think you would expect this. What's interesting is that only 10% of them have severe problems with self-care, and only 5% reporting severe or extreme impairments in their mood, which is interesting. It's not what we might have expected. And maybe there might be a little bit of a responder bias in that those in this group on 15 or more medicines were more likely to agree to participate if they were feeling a little bit better at that time. Then looking at treatment burden, again, as you might expect, most of them are reporting treatment burden, but only 25% of them saying that they have high treatment burden, whereas we might regard this group as having high treatment burden just on the basis of their prescriptions. And we have a phrase that we use, where I practice is an area of deprivation. And particularly during COVID, some of my GP colleagues are talking about our patients being the unworried, unwell. What is it? The unworried, unwell, exactly. And I wonder, maybe these significant polypharmacy patients have kind of habituated to being on all of these medicines, and they have adapted to it in some way. So it's interesting to see what their treatment burden is. And then finally, in relation to the patient-reported outcome measures, is the information on their attitudes towards deprescribing, which is very like Barbara's earlier work on OptiScript. Over 80% satisfied with their medicines while simultaneously being prepared to stop their medicines. So there's not a sense of great agency for themselves. And this is the group of people who in OptiScript are very trusting of their GPs. Then when you look at the burden domain, which is the data presented in the figure there, 40% of them are agreeing that their medicines are a burden. So they're satisfied, and yet they think it's a burden, which is really an interesting and kind of slightly conflicting position for them to hold. And again, important for us to understand. This is more data that we have, and this is immediate post-intervention data. So this is captured from the website that the GPs used. So we've 26 intervention practices, and the black columns are the number of participants in each practice, and the gray columns are the number of reviews that were done in that practice. So you can see that for most practices, they managed to do a Spire review on nearly all their patients. There were 2 practices that didn't get any of them done for reasons of pressure of time. And there were a few practices where they didn't get all of the reviews done, sometimes because the patients became unwell or they had staff changes or whatever. And then the jagged line you can see is the mean reduction in number of medicines post-review. And what you can see there is huge variation between the practices, with some variations from changing absolutely nothing. Their GP 13 on the third set of columns, same number of medications at the beginning of the review as there was at the end of it, whereas GP 68 had stopped a mean of 7 medications, which is a really interesting difference between those 2 practices. So what can we say about this particular intervention at this point? Well, not all practices will be able to complete reviews, but of the 208 intervention patients, 80% of them did get a medication review. So that is reasonably good, and we are doing an intention to treat analysis, and we have planned a per protocol analysis as well, which will be interesting. There was certainly immediately post-intervention a mean reduction in medicines of 1.7, which would be an effective intervention in terms of what we were hoping to achieve. Again, I'm not sure that will be of clinical significance, and we can maybe have some discussion around that. And it did raise a big issue about what constituted an improvement from a practice perspective. So you can look at that practice where they made absolutely no changes at all. And there's 2 possible scenarios. One is that they just carried on regardless, the intervention had no effect on them, and maybe there was a whole load of inappropriate prescribing going on. But the other possibility is that they were running a really tight ship, that all their patients were regularly reviewed, and every single patient had appropriate prescribing to begin with. And just looking at our data won't tell us what type of practice that was. And we will be doing a process evaluation and a qualitative analysis of what was going on in the practices. And the practices where they made huge changes to prescriptions, maybe they were doing this, there was just this idea that they were tidying up prescriptions. There was a load of items on scripts that weren't actually being taken by patients. Now, it's probably a good idea to do that because, these were all prescriptions that had been given to patients. So they could have got any of these items, but if they weren't taking them, they weren't harming them. And then the other message we were getting from GPs was that they found it very hard to do these reviews if they didn't know the patient well. So in Spire, there was one GP in each practice who did the training and undertook the reviews. And if you were doing this in the real world, of course, the GP of each patient would do the training, and therefore it would be embedded in their ongoing relationship, which would be likely to be more effective. So the initial messages from Spire. The other thing that was surprising to us was the high event rate. There's been a 5 to 6% mortality across the trial at follow-up. And that's balance between intervention and control, and is, it's quite stark. And then nearly equal numbers being admitted to nursing homes. So they're a very vulnerable population. And then this is where we get to our debate around the 15 plus medicines versus 10 plus. Maybe it's a bit late to be intervening for this group. On the other hand, hopefully, if they were, for many of them who have remained ambulatory, maybe this will have made an impact for them. Recruitment was extremely challenging. Interestingly, we had the most interest from practices that we've ever had for any study. So 125 practices expressed an initial interest and were invited. 70 provided practice profile data, but for many of them, it just didn't work out in terms of trying to identify enough patients. And we ended up with 51 who proceeded to recruit enough patients to participate in the trial. So only 41% of the initial interested practices ended up participating. And then across those practices, of nearly 1,800 patients identified as being eligible and invited, only 442 agreed to participate. There was about another 50 patients who were in practices that didn't recruit enough patients to stay in the trial and who ended up just getting the intervention materials. So, but it's still a very low response rate from patients. Again, probably indicating the degree of burden that they're already living with. And then the kind of barriers, again, we'll know much more when we do a formal process evaluation, but certainly the software finder tool that was used to identify patients was erratic, and it didn't seem to work brilliantly in all practices. And that might have been due to practice variation in how they recorded their prescriptions. And also our website, we had very little money for a website, and it was really basic and clunky and didn't save brilliantly. And that did drive some of the GPs crazy. And that is another lesson learned. Also, the trial was conducted in the context, we had just come out of a really serious recession with 25% cuts to practice payments, and lots of young doctors emigrating. So it was a very challenging time for practices to be conducting these kind of reviews, particularly given the complexity of these patients. So before I finish up, and very happy to take questions, I'm going to just move on. I've just got 2 other slides just based on some other work we've done in our center that would be alternative approaches to deprescribing. And the first is a feasibility study that we've done on family practice-based pharmacists, and this has been published this year in BMJ Open. And one of the aims, so in the UK, it's now nearly the norm to have pharmacists embedded within primary care teams in general practices, but it isn't the norm in Ireland. And interestingly, there's not a lot of evidence, robust evidence around its effectiveness. So one of the aims of the pharmacist being based in the general practices in our feasibility study was to look at deprescribing. And there were 136 chart-based medication reviews conducted by the pharmacists. And of course, we then came across a very interesting dilemma in that there was a lot of deprescribing, but a good proportion of it was actually to address potentially inappropriate prescriptions. So if we had counted all the medicines stopped when they were addressing PIPs, we would have double counted deprescribing and addressing PIPs. So we decided that we would, any medication that was stopped because it was addressing a PIP would be counted that way. And then any other medicine stopped would be counted as deprescribing. And you can just see here, I mean, again, you'll know this, the variation in deprescribing depending on the drugs. So that the other category was the most common for deprescribing, and you can see the huge range in medications. And essentially the message we got was that these were medications that people were no longer taking or finding useful, and therefore they were relatively easy to deprescribe. Z drugs or hypnotics, very hard to deprescribe, and you probably need a specific intervention to do that. And then antihistamines, beta histidine, about 50% deprescribed, and bisphosphonates look better, but obviously the numbers for all of these are very small. So then looking at these are 2 studies that Frank Moriarty, who has traveled in Canada and the States, a pharmacist based, no longer based in our research center, but still luckily in our institution. Frank has looked at the very good resource in the UK, the Open Prescribing, resource where you can drill right down to the level of a general practice. And what you could do is you could target specific drugs for deprescribing and then conduct audit and feedback for prescribers. And that would be one potential approach. And then the other thing that Frank has looked at, he's looked at practice variation in relation to regulatory approaches to medicines. And now regulatory guidance is usually issued when there's a safety concern, but you could consider deprescribing in that context. But if you were going to do that, what Frank showed was really considerable variation in how practices respond to these safety alerts or safety guidances. So you'd need to incorporate that consideration if you were going to use it for deprescribing as well. So to conclude, I suppose my main message is that deprescribing sits in the context of multiple moving parts. And certainly for patients and clinicians, it's difficult to pull apart the strands of polypharmacy and multimorbidity and PIP and prescribing cascades. They all happen simultaneously to the patient. Research in this area is a real challenge, but it is really clinically important for patients. We have a lot of questions around who we should be targeting, what are effective interventions for which groups of patients, and what are appropriate outcomes that will have clinical importance. For me, the really key issue is clinical impact of what we're doing, but I accept that costs matter as well. And that's where you get back to this issue of proton pump inhibitors driving assessments of PIP. Actually, increasingly, we are aware that having long-term acid suppression may not be a good thing. And we are probably over-prescribing proton pump inhibitors. So it could well be that there's serious clinical benefit to deprescribing them as well, but certainly there are cost benefits. But I want to finish up on a phrase from one of the patients in OptiScript, in the qualitative evaluation of OptiScript, which I think says why deprescribing matters, which is that nobody wants to take more medications than they need to. So I'm just going to finish by acknowledging my colleagues in our research centre, in the funding from the Primary Care Trials Network, and particularly all the GPs and patients who've participated in the included studies. So thank you very much. And that's just a picture of the team and some contact details if anyone wants to make contact. So I will stop sharing, I think, so that we can have a discussion.
Thank you, Dr. Smith, for an incredible overview of the complexity of this, deprescribing polypharmacy, multimorbidity, and we're excited to hear more from you soon about your the impact of your intervention from SPIRE. Just to remind the audience that we are taking questions through the Q&A box in the Zoom screen. If you can't find that, you can also put questions into chat. And Dr. Smith, we have 4 questions so far, so I will read them. From Raul Medina, a question, it begins, it is interesting that 96% of patients feel positive about taking multiple medications. And do you think it has to do with the perception that medications keep them safe and or healthy?
Well, I think there's a lot in that. I think that it is down to this idea of trusting their doctors or their pharmacists, and that they, if their doctor says they need it, they're prepared to take it. But meanwhile, they still have these concerns that are coexisting with this satisfaction and this trust, which is kind of contradictory and very interesting, and probably needs to be unpicked if we want to really address deprescribing. I mean, I'm welcome anyone else stepping in from other panelists, or I know there's a lot of people to get involved in a discussion.
Okay. Just in case, while people think about perhaps the other panelists have thoughts, the next question from Jinjiao Wang is, I wondered for patients with multimorbidity and polypharmacy who often also have multiple prescribers, what is the effect on medication reconciliation alone on outcomes versus medication reconciliation plus deprescribing?
Okay. I didn't even mention MedRec,
Yeah.
which is another whole area of research. And actually, you know, one of our postdocs, GPs, Patrick Redmond, did his PhD on that and leads the Cochrane Review on Medicines Reconciliation. It's a huge issue. And so these patients are definitely crossing the primary-secondary care divide all the time. And they are experiencing changes. We know we've done some work where we've looked at prescribing in older people, and about 30% of the prescriptions are initiated in specialty care. And qualitative research we've done with GPs, they're very reluctant to stop those medicines because they don't quite know why they were started. And there's, you know, certainly you're less likely to cause any trouble if you leave everything the same. Whereas if you're the one person who stopped that ACE inhibitor and someone gets admitted with heart failure the next week, you know, they and their family will certainly blame you for that. So I think a lot of primary care physicians, they need support and they need permission in some ways, and systems in place to allow for that deprescribing, particularly of higher risk medications. We are recording adverse drug withdrawal events in SPIRE, but I don't have data yet on that. But again, that's another concern. And how do you disentangle an adverse drug withdrawal event from, you know, an existing deterioration in underlying conditions? Because you know, 5 to 6% mortality, these are a group of patients who are not well and things are happening to them all the time. So you're making changes in that context. And you would certainly need to have recorded very good records, that you've had discussions with people, that they're making informed choices, and that you monitor the situation, that they know that you have a lot of safety net advice put in place, that they know what to do if they get breathless again, or all those kind of things. So it is challenging clinical practice, there's no doubt about it.
Right. So it's not just about the GPs, it's not just about inertia, it's about there's some other issues when faced with medications you don't know the rationale for.
Well, but certainly some of the GPs inspire. Like, I mean, I remember myself in some of the piloting work, you know, you could spend 15 minutes trying to work out why somebody was put on a diuretic 30 years ago. You know, they've only been your patient for 10 years. And you're wondering, well, is it because were they put on it inappropriately because they had a bit of ankle swelling? Or like, if I stop it, are they going to decompensate? So yes, it's more than inertia. I would agree with that.
Great. Okay. Another question. Can you comment on criteria that you set for the pharmacists involved in the SPIRE intervention? So training, geriatric certification. Okay.
Well, there were no pharmacists involved in the actual intervention other than informing its design and the identification. So for SPIRE, the GPs themselves identified the inappropriate prescribing. We have pharmacists who are screening prescriptions for outcomes, but they are research pharmacists. In the general practice-based pharmacy study, which maybe this person is thinking of, the pharmacists, they are community pharmacists who often then move into a role of working in a family practice. And they wouldn't just be working with older patients. They would be working right across the clinical spectrum. And there are, I think there's increasingly training programs for such pharmacists and accreditation processes as well. But my understanding is that they usually come from community pharmacy and then move across into general practice-based pharmacy roles.
Thank you. So we have a number of questions. I may not be able to get all of them, but there are a number of questions about measures. One is about measure of multimorbidity, and did you use, for example, the Charlson Comorbidity Index or other measurement, and also how sick the patients actually are with their conditions?
Okay, it's a pragmatic trial. Multimorbidity is defined as 2 or more chronic conditions, but we haven't yet counted up the conditions for these patients. But if they're on 15 or more medicines, they will definitely qualify as having complex multimorbidity, which is usually defined as 3 or more conditions from 3 different body organ systems. We wouldn't have used, we don't use Charlson very much because it was originally more of a hospital-based kind of derived measure. But if we had been using any severity index, we would probably have used one of the ones developed by colleagues like Martin Fortin or Elizabeth Bayliss. But again, those measures require quite a little bit of extra work to work out the severity. So we don't have, other than the fact that they're on 15 or more medicines, we don't have additional, we have treatment burden, but we don't have condition severity.
Thank you. Another question about measurement and definition. How did you identify PIPs? There's a countless number of drug combinations that are potentially inappropriate.
Okay, so people are probably familiar with the explicit prescribing indicators, things like Beers and stop-start. So essentially for OptiScript, we had a kind of a consensus process using those indicators to identify those that had some, that were applicable to Ireland and had some reasonable community prevalence. So there was a list of indicators that were predefined and they were used to identify PIP. So the GPs were trained, they were provided with that list, and it would be things like therapeutic class duplication, inappropriately long prescribing of high-dose proton pump inhibitors, opiates, dual classes of opiates, opiates without laxatives, the co-prescribing of diuretics and ACE inhibitors without monitoring of renal function, all the usual ones. But they were based on explicit prescribing indicators that are well known in the literature.
Great. So what did patients say after knowing that they had been prescribed potentially inappropriate prescriptions? And what do you do to preserve, if that's the right term, the patient-physician relationship with this, with this knowledge?
Well, I guess we really emphasize the potentially. And it's not just the patients who are sensitive about that, about when we started off this work around 9 or 10 years ago, I was incredibly cautious about even using the terminology, because I think a lot of GPs and pharmacists might have found it a little bit offensive. But over the years, I think once you say very clearly that it depends on the patient, and when you say, well, it might be potentially inappropriate to be prescribing a non-steroidal anti-inflammatory, for a long time in somebody who's over 65. But if that patient has crippling pain and this is the only thing that can relieve it, then that prescription will continue. So we're not saying that these are wrong prescriptions, and there's no question of them being errors. They're just prescriptions that need to have more caution around them. And so I think that's how we present it to patients, is that we're trying to improve prescribing and improve the safety of prescribing, rather than focusing on it being in any way around mistakes or errors.
Right. Okay, good. So I'll pose one more question and then turn it back over to Jen. So given the difficulty recruiting and dropout rate, should there be targeting of another age range, perhaps an earlier age range, and more preventative intervention, or other targeting that you might consider?
Well, I think the answer is yes, but the question is how and who. So we have a grant application in for EU funding at the moment, where we are trying to work out with a group of researchers across 6 different countries what you might call what the sweet spot is. So who are the group of patients who are not too well enough? So those earlier trials I mentioned that were conducted in Germany no effect will be shown because the patients actually are okay, and we shouldn't be bothering them basically if they don't have a problem. Or maybe the Spire group, have too many problems. So there's some group in between, and maybe it's around 10 or more medicines. But we're hoping to do some more kind of pharmacoepi work in Denmark, where they have really excellent linked data sets, trying to work out who are the right population to be intervening with. One of the problems, I mean, we've done other multimorbidity research studies in younger patients, is that middle-aged patients are often working and they're very busy. And unless you can design an intervention that makes their life easier, it's probably, they're not going to be any easier to recruit than these patients were. And I think that's where we really have to focus our efforts, is around interventions that reduce the burden on patients and on practitioners. And if they can see there's something in it for them, then hopefully they will participate.
Great, thank you very much. I'll just mention that there are also some thanks in the questions and answers. Great presentation, brilliant presentation, and deprescribing should be part of the pharmacist curriculum. And now I'll turn it back to Jen. Thanks again, Dr. Smith.
Thank you.
Thank you so much, Dr. Smith. That was just absolutely brilliant, like everyone else has said, and we certainly learned a lot. Thank you for taking the time. So this brings us to the conclusion of our webinar. Thank you all for attending today's webinar. The recording of the webinar will be posted on the US Deprescribing Research website. Please remember to fill out our short evaluation survey that will be emailed shortly. And please take a look at our next webinar, which will be Tuesday, November 24th at 2 p.m. Eastern Time. It's Dr. Zachary Markham from the University of Washington. He will be presenting pharmaceutical use and brain health. Please register through the website. Thank you all again and have a wonderful day.